Hi everyone, I'm Chelvin from Singapore. Today, it gives me great pleasure to share about the Hydrus Microstent. These are my financial disclosures. I've implanted mixed devices for over a decade, and as an early adopter of the mixed technology in Asia, I can say that in all honesty, the Hydrus is one of my favorite mixed devices. The Hydrus is an 8mm implant made from nitinol, which is highly biocompatible and has been used in cardiovascular stents. The curvature of the Hydrus matches the Schlemm's canal. There are 3 windows on the device with a transition zone and an inlet. The juxtacanalicular trabecular meshwork is thought to confer the largest degree of aqueous outflow resistance, and trabecular bypass devices like the Hydrus circumvent this and drain aqueous directly from the anterior chamber to the Schlemm's canal. The Schlemm's canal is this very small structure in the angle of the eye. For any of the trabecular bypass devices to work, they have to be placed well in the canal, which is easier said than done in some cases. The Hydrus has a trimodal mechanism of action, not only bypassing the trabecular meshwork, but it is the only device which also scaffolds and dilates it over 3 clock hours. It is important to select appropriate patients for Hydrus surgery. In our BJO editorial on the coming of age of MIGS, we highlighted that patient selection is crucial for the success of MIGS, and the Hydrus is no different. This patient has a failed trap, cup disc ratio of 0.9, IOP of 26, on 4 glaucoma medications, and documented glaucoma progression, with a small central island of vision. This is not the sort of patient who would do well with a Hydrus, and this patient should have tube surgery instead. Choose patients with early to moderate open-angle glaucoma who are controlled on 1 to 2 glaucoma medications, especially for your first few surgeries. Trabecular bypass MIGS has a particular role as a phaco-plus procedure, and cataract surgery gives us a unique opportunity to implant one of these devices to reduce the patient's medication burden, effectively killing 2 birds with 1 stone. How is the Hydrus implanted? For the smaller trabecular bypass mixed devices, you will need to target the location of the device to the aqueous veins and collector channels. The Hydrus spans 3 clock hours, so you can really put it in any part of the angle that is accessible, and it will almost certainly be in an area with collector channels. To implant the Hydrus, you can choose either topical or regional anesthesia, depending on how cooperative the patient is. To get a view of the anterior chamber angle, the microscope should be tilted about 35 degrees towards you, and the head is also tilted about 35 degrees away from you. There are many different direct gonioscopes in the market, which differ in terms of their magnification, field of view, and contact area with the eye. My preference is for the Hill gonio lenses, which give 1.2 times magnification, 90 degrees view, and a relatively small contact area with the cornea, making it easy to manipulate the device in the eye without distorting the cornea. Look out for these pitfalls causing a poor view of the angle. Visualization is absolutely key when performing successful Hydrus implantation, so it is worthwhile spending more time to optimize your view of the angle. Even before implanting your first Hydrus, it is very useful to practice gonioscopy on standard cataract patients at the end of your surgery. The cornea incision is made about 3 to 4 clock hours away from the target site of implantation. The location of the cornea incision is important, so as to ensure that the Hydrus enters the Schlemm's canal at the correct angle, which is not too steep. So you may need to make a separate incision from your phaco incision. For any mixed device, familiarize yourself with the injector before the surgery. And the Hydrus injector is really well designed and easy to use. There is a wheel that you can roll to push out the implant. And usually I roll it out until I just see the implant, then I retract it until it's just inside the injector. The cannula tip can also be rotated to make it comfortable to turn the wheel with the index finger while still keeping the cannula tip horizontal. Practice pushing the Hydrus all the way out and then re-grabbing it with the injector. before your first surgery. To implant the Hydrus, fill the eye with viscoelastic, and most surgeons prefer a cohesive viscoelastic. Check that the eye is not too soft or too hard. If it is too soft, there will be corneal striae. If it is too hard, the Schlemm's canal will collapse and it will be difficult to insert the Hydrus into the canal. Before opening the Hydrus, ensure that you have a good view of the angle. Focus downwards until the angle is well seen. Then bring out the injector, and I would usually rotate the cannula tip 2 clock hours clockwise. Insert the cannula tip into the eye, being careful not to cause trauma to the cornea, iris, or lens. Angle the cannula upwards so as to avoid hitting the sclerospur. And pierce the upper 1/3 of the trabecular meshwork. I like to push a bit more against the back wall of the Schlemm's canal to ensure that the cannula has gone through the entire trabecular meshwork and has entered the canal. Once it is in, flatten the angulation so that the cannula is no longer angled upwards but is parallel to the canal. Turn the wheel to push out the Hydrus, and here there's a slight resistance. Adjust the angulation slightly upwards, then the Hydrus rolls out very smoothly. You shouldn't feel any resistance at all during implantation, and ideally, half the transition zone should stick out into the anterior chamber. When the Hydrus is well inserted, there's obvious blanching of the aqueous veins in the left part of the video where the Hydrus is inserted. This is a very smooth and easy Hydrus implantation. After piercing the trabecular meshwork, the Hydrus is inserted without any resistance at all, and the positioning of the implant is ideal. After removing the viscoelastic, and when vision blue is injected into the anterior chamber, you can see the aqueous veins turn blue. This shows that just one Hydrus accesses such a large area of aqueous veins. The Hydrus can be inserted too superficially, and that's why it's important to ensure that the whole cannula tip is through the trabecular meshwork before inserting the implant. If the Hydrus is too superficial, it appears shiny, and if this happens, retract the implant and reinsert it. If the Hydrus is not inserted well, for example, if it dips posteriorly into the suprachoroidal space, remove the implant. As shown earlier, it is important to practice reloading the implant with the injector. After removing the Hydrus, then pierce the trabecular meshwork a bit downstream of the initial intent. And now it goes in very smoothly. If the nasal angle is too macerated by multiple attempts at implantation, you can also implant the Hydrus in the inferior angle and ask the patient to look down or tilt the chin downwards. For high myopes, be very mindful that they often have a larger white-to-white and the Schlemm's canal curvature is less curved than a normal eye. In this video, initially the angle of implantation was too steep, so the Hydrus keeps hitting the back wall of the Schlemm's canal and was unable to enter the canal. There was a lot of resistance felt when turning the wheel, and it's important not to turn the wheel forcefully when you encounter resistance. As the wheel was turned, instead of the Hydrus advancing, the injector was pushed backwards. In such a case, remove the implant, readjust the angle of approach, make it flatter, and finally, the implant goes in easily into the canal. Check that you can see all 3 windows of the Hydrus in the canal to verify that it is correctly implanted. So after mastering Hydrus implantation, what sort of outcomes would you expect to achieve? In the Horizon study, which is the FDA pivotal study, 77% in the Hydrus group achieved the primary endpoint, and there was a 7.6% decrease in IOP. About 3/4 in the Hydrus group were medication-free at 2 years, and about 2/3 were medication-free at 5 years. The Hydrus is the only mixed device shown to reduce the incidence of subsequent incisional glaucoma surgery. This makes it very compelling for a glaucoma patient with a visually significant cataract to choose combined phaco-Hydrus rather than phaco alone, even if the glaucoma is well controlled on medications. There were no significant differences in adverse events between phaco-Hydrus and phaco alone during the 5 years after surgery, and in particular, no device-related endothelial cell loss from Hydrus. There were some cases of device occlusion with iris. If the IOP is increased, laser can be used to clear the iris, or a glaucoma eye drop can then be restarted. The COMPARE study was a prospective randomized trial comparing the Hydrus with 2 iStent G1 devices. Significantly, 20% more eyes were medication-free after the Hydrus Microstent compared with after 2 iStents. These results are consistent with the findings of the Cochrane review that the Hydrus Microstent is more effective than the implantation of 2 iStents. These are some histological slides showing the current trabecular bypass mixed devices in the Schlemm's canal. The Hydrus is more effective than its competitors because it is the only device that dilates the Schlemm's canal. In contrast, sometimes you're not even sure that the iStent inject is in the canal, as shown in the slide. I've shown quantitatively with OCT angiography that there is a reduction in flow signal in the episcleral vasculature after Hydrus implantation, confirming that there is indeed increased aqueous drainage in the aqueous veins. In summary, the Hydrus Microstent is the only mixed device that bypasses the trabecular meshwork and scaffolds the Schlemm's canal over 3 clock hours. There is substantial evidence that Hydrus implantation is an effective and safe minimally invasive glaucoma surgery, especially in the context of a phaco-plus procedure. I hope that you found this talk useful, and please feel free to download our open access book on MIGS. I wish you all the best in your Hydrus surgeries.